Hematology CLSR review. Prenatal hematopoiesis begins in the yolk sac. From the first month, it becomes more and more in the liver and spleen until the fourth month, when it starts increasing in the bone marrow and lymph nodes. Active adult hematopoietic tissue is in the flat bones. The colony-forming units are in the red marrow. This is the skull, sternum, pelvis, ribs, and vertebra. Heme synthesis. 1. Must have iron and protoporphyrin. 2. Iron transport and storage. A. Transferrin, iron transport protein. B. Ferritin, major iron storage form. C. Hemosiderin, H2O insoluble iron storage form, long term. D. Excess iron will be stored in tissues and body organs, which can lead to hemosiderosis, hemochromatosis, or organ damage. 3. Protoporphyrin synthesis. A. Precursors. See memory tool below. B. Porphyrias. Enzyme deficiencies cause buildup of heme precursors, red or port wine colored urine. Early precursors, delta ala or porphobilinogen. Neuropsychiatric symptoms, i.e. acute intermittent porphyria or AIP. Later precursors, UR-COP, PROTO, cutaneous symptoms such as photosensitivity, facial hair. Heme precursors, delta aminolevulinic acid, porphobilinogen, uroporphyrinogen, coproporphyrinogen, protoporphyrin. Heme plus globin for hemoglobin. Porphyrias. Excessive formation of porphyrins occurs if any enzymatic step in heme synthesis is blocked. Sites of inhibition by lead. Hemoglobin types in newborn and adult. Gower 1, which has globin chains zeta 2, epsilon 2, is embryonic. Gower 2, which has globin chains alpha 2, epsilon 2, is embryonic. Portland, which has globin chains zeta 2, gamma 2, is embryonic. Hemoglobin F, which has globin chains alpha 2, gamma 2, is 60 to 90% in the newborn and 1% in the adult. Hemoglobin BA2, which has globin chains alpha 2, delta 2, is less than 2% in the newborn and 2% in the adult. Hemoglobin BA, which has globin chains alpha 2, beta 2, is 10 to 40% in the newborn and 97% in the adult. In the hemoglobin oxygen dissociation curve, a shift to the left means that O2 is not released to the tissue easily, and pH is up, and the high affinity hemoglobin F is present and requires multiple transfusions, a decrease in 2,3 dpg. A shift to the right means that oxygen is released to tissue more easily, pH is down, and 2,3 dpg is increased. Basic laboratory procedures. Anticoagulants. 1. EDTA, ethylene diamine tetraacetate, chelates calcium++. 2. Heparin, antithrombin agent. Hemoglobin. 1. Principal oxidation of hemoglobin to methemoglobin using KCN and K-ferricyanide or sodium lauryl sulfate. 2. Sources of error. A. Lipemic icterus. B. High white count. Or C. Resisting hemoglobins, i.e. SS or CC. 3. Reference range. Male, 16 plus or minus 2 grams per deciliter. Female, 14 plus or minus 2 grams per deciliter. Hemoglobin variants. Methemoglobin, iron plus plus oxidized to iron plus plus plus. Brown, cannot bind O2. Carboxyhemoglobin, increase in carbon monoxide poisoning and smokers. Cherry red. Sulfhemoglobin, only hemoglobin not measured by cyan methemoglobin method. Hematocrit. 1. Measures packed cell volume in percent. 2. Microhematocrit method. A. Can use fingerstick, EDTA, or heparinized sample. B. Sources of error. Failure to seal tube adequately. Incorrect reading due to uneven clay plug. Inappropriate centrifuge time or speed. Excess EDTA resulting in red blood cell shrinkage. 3. Automated method. A. Coagulated from MCV and RBC. B. Sources of error. Cold agglutinins or high white blood cell count. 4. Reference range. Male 47 plus or minus 5%. Female 42 plus or minus 5%. Manual cell counts. 1. White blood cell or platelet count. A. Diluent 1.98 milliliters of 1% ammonium oxalate. B. 0.02 milliliters or 2 microliter pipette. C. 1 to 100 dilution or 0.02 milliliters in 2 milliliters. 2. Hemocytometer, Neubauer, which is a 3x3 grid, the center of which is a 5x5 grid, 1 millimeter grid lines. 3. Calculations. The formula is the number of cells counted times 1 over total volume times dilution factor. The volume of one square is length times width times depth, and the total volume is volume times number of squares counted. A. White blood cell count. Count all 9 squares. The total volume counted is 1 millimeter times 1 millimeter times 0.1 millimeter times 9, which equals 0.9 millimeters cubed. The reference range is 5,000 to 10,000 microliters. B. Platelet count. Count all 25 squares in the center large square. Total volume counted is 1 millimeter times 1 millimeter times 0.1 millimeter cubed, which equals 0.1 millimeter cubed. The reference range is 150,000 to 400,000 microliters. For MCV, the formula is HCT over RBC times 10. The reference range is 80 to 100 fluid ounces or microliters cubed. If the MCV is less than 80, it indicates microcytes. If it is greater than 100, it indicates macrocytes. MHC. The formula is HB over RBC times 10. The reference range is 28 to 32 pg. The indications vary with hemoglobin content and cell size. MCHC. The formula is HB over HCT times 100. The reference range is 32 to 36 gram percent. If the MCHC is under 32, the indication is hypochromic cells and icterus. If it is over 36, it indicates spherocytes, icterus, lipemia, hemoglobin SS, or CC. MCV is directly measured by automated methods. Hematocrit is calculated from MCV and RBC count. Red cell. The reference range for females is 3.8 to 5.2 times 10 to the 6th microliters. The reference range for males is 4.5 to 6.1 times 10 to the 6th microliters. Its function is O2 transport to tissue and carbon dioxide removal from tissue. Neutrophils. The reference range is 45 to 70%. Absolute 2250 to 7000 microliters. And its function is to ingest and kill bacteria. Lymphocyte. The relative reference range is 20 to 40%. Absolute 1000 to 4000 microliters. Its function is humoral and cell-mediated immunity. The monocyte. Relative reference range 3 to 10%. Absolute 150 to 1000 microliters. Its function is to ingest and kill bacteria, digest debris, initiate and regulate adaptive immune response. The basophil. Relative reference range 0 to 2%. Absolute 0 to 200 microliters. Its function is the inflammatory response mediator. The eosinophil. Relative reference range 0 to 3%. Absolute 0 to 300 microliters. Its function is allergic response regulator. The platelet. Absolute reference range 150,000 to 400,000 microliters, and its function is clotting. Blood smear examination. 1. The right stain. A. Polychrome Romanowski stain. Phosphate buffer, pH 6.4. Eosin, methylene blue, and methanol, which is the fixative. B. Sources of error. Stain too blue, pH of buffer or stain too basic, prolonged staining. Stain too red, pH of buffer or stain too acid, prolonged washing. 2. Leukocyte differential. A. Normal relative percent values. See chart above. B. Absolute values. Calculation. Relative value percentage times total white blood cell count. Example, total white blood cell count is 6,000 microliters. The percent of neutrophils from the differential is 60%. Absolute neutrophil count, 0.6 times 6,000 equals 3,600 microliters. C. Significance of increased leukocytes. Neutrophils are increased in bacterial infections. Lymphocytes are increased in viral infections. Monocytes are increased in tuberculosis, syphilis, and malignancies. Eosinophils are increased in allergies and parasites. Basophils are increased in immediate hypersensitivity. D. White cell morphology. Hypersegmented neutrophil, which is associated with megaloblastic anemia, B12, and folate deficiency. Hyposegmented neutrophil is associated with Pelger-Hewitt, pseudo-Pelger-Hewitt, AML, which is acute myeloid leukemia, and AIDS. Toxic granulation and vacuoles are associated with bacterial infections, burns, and chemotherapy. Dolly bodies, which are made of RNA, are associated with bacterial infections, burns, and May-Heglin. Variant lymphs, increased size and basophilia, are associated with infectious mono and other viral infections. 3. Platelet estimate. A. 8 to 20 oil immersion field, adequate. B. If platelets seem low, check feather edge of slide for platelet clumping. Check for satellitism, EDTA-related redraw in sodium citrate. C. Check platelet size. If they're large, Bernard-Solier, May-Heglin, myeloproliferative disorders, or stress platelets. 4. Nucleated red cells. A. Must correct white cell count if included in count. B. Formula. White blood cell count times 100 over 100 plus number of nucleated red blood cells equals the corrected white blood cell count. 5. Red cell morphology. A. Size. Normocytic, MCV of 80 to 100. Microcytic, MCV of less than 80, macrocytic, MCV of over 100, anisocytosis, variation in size, RDW greater than 14.5. B. Color. Normochromic, MCHC of 32 to 36. Hypochromic, MCHC of over 32. Hyperchromic, MCHC of under 36. Polychromasia, blue-gray color in red blood cell. If stained with new methylene blue, these would be reticulocytes. C. Shape, biconcave disc. Poikilocytosis, variation in shape. D. Inclusions. E. Crystals. Hemoglobin C, bar-shaped. Hemoglobin SC, hand-in-glove or Washington Monument. Abnormal red cell shapes. Acanthocytes look like a star drawn by a kindergartner and are seen in abetalipoproteinemia, severe liver disease. Echinocyte Burr cells look like a giant mutated nerd candy and are seen in uremia or artifacts like alkaline glass effect. Elliptocyte has a little indentation in the middle, and it's seen in hereditary elliptocytosis, iron deficiency, and thalassemia. Macroovalocytes are seen in megaloblastic anemia. Helmet or keratocytes are like little half moons, and they're seen in hemolytic processes. Schistocytes or red blood cell fragments are seen in DIC and hemolytic processes. Sickle cells or drepanocytes are little French fry looking cells, and they're seen in hemoglobin SS. Spherocytes are just completely circular cells, and they're seen in hereditary spherocytosis, increased MCHC, ABO-HDN, and other hemolytic processes. Stomatocytes, or mouth cells, are seen in hereditary stomatocytosis and liver disease. Target cells, or codocytes, which have a little circle in the center, are seen in liver disease, HBC, thalassemias, and other hemoglobinopathies. Teardrop cells, or dacrocytes, are seen in extramedullary hematopoiesis, thalassemias, and pernicious anemia. HDN is hemolytic disease of the newborn. DIC is disseminated intravascular coagulation. Red cell inclusions. Howell Jolly bodies have a little dot within the cell, which is composed of DNA. It is stained with white and new methylene blue, and it indicates disturbed erythropoiesis, hemolytic anemias, megaloblastic anemia, and post-splenectomy. Basophilic stippling, which are little dots all throughout the cell, are composed of RNA, and they're stained with white, new methylene blue. Indications are thalassemia or lead poisoning. Pappenheimer bodies, which are a few dots within the cell, are composed of iron, and they're stained with white and confirmed with Prussian blue. They indicate sideroblastic anemia or hemoglobinopathies. They're also called siderotic granules or siderocytes. Heinz bodies are larger dots throughout the cell, are composed of denatured precipitated hemoglobin. They're stained with supravital stain, such as brilliant crescel blue or new methylene blue, and are not seen with white stain. They indicate G6PD deficiency, thalassemia, or unstable hemoglobins. Cabot rings, which are figure eights with one dot in them within the cell, are composed of remnants of mitotic spindle. They're stained with the right stain, and they indicate megaloblastic anemia. Parasites, which are composed of malaria, Babesia, trypanosomes, are stained with right stain and indicate parasitic infection. The rule of 3 is the correlation of hemoglobin, hematocrit, and red blood cells. Hemoglobin times 3 equals hematocrit plus or minus 3%. Red blood cells in millions times 3 equals hemoglobin plus or minus 0.5. If the rule of 3 doesn't fit, consider 1. Clotted sample, 2. Cold agglutinin, in which case you would warm the sample and rerun, 3. Lipemic, icteric, or grossly hemolyzed sample, 4. Resisting hemoglobin, which would be SS or CC, 5. Abnormal red cells. Increased MCV, increased MCHC, and decreased red cell count are associated with cold agglutinin disease. Warm the sample and rerun. Normal heme levels. HB in women 14 plus or minus 2 grams per deciliter. In men 16 plus or minus 2 grams per deciliter. Hematocrit in women 42 plus or minus 5%. In men 47 plus or minus 5%. Red blood cells in women 4.5 plus or minus 0.7 times 10 to the 6th microliters. In men 5.3 plus or minus 0.8 times 10 to the 6th microliters. White blood cells 5 to 10,000 microliters. Platelets 150,000 to 400,000 microliters. Erythrocyte sedimentation rate. 1. Principle. Measures rate of fall of red cells through plasma. 2. Reference ranges. Female 0 to 2 millimeters. Male 0 to 5 millimeters. 3. Clinical correlation. A. Increase seen in presence of increased plasma proteins, primarily fibrinogen and globulin. Inflammation or infection. 4. Sources of error. A. Increase tilting tube, increase temperature. Decrease specimen too old, decreased temperature, or excess EDTA. Reticulocyte count. 1. Uses a supravital stain which stains red cells in living state. A. New methylene blue. B. Brilliant crescel blue. 2. Monitors erythropoiesis. 3. Calculations. A. Percent reticulocytes equals number of reticulocytes in 1,000 red blood cells divided by 10. B. Absolute reticulocytes equal the number of red blood cells times the percent of reticulocytes. C. Corrected reticulocyte count is the percentage of reticulocytes times the patient hematocrit divided by 45. Reference ranges 0.5 to 1.5%. RPI, reticulocyte production index, is the corrected reticulocyte count over the maturation time, which is usually 2. A. Greater than 2, adequate bone marrow response to anemia. B. Under 2, inadequate bone marrow response to anemia. 6. Increase in hemolytic anemias, post-acute blood loss following therapy, e.g. iron, folate, B12. Special hematology. Bone marrow preps. 1. Reference ranges. A. Megakaryocytes, 5/10x field. B. Myeloid, erythroid ratio 3 to 1 to 4 to 1. 2. Clinical correlations. A. Dry tap, aplastic anemia, myelofibrosis. B. Decreased M to E ratio, erythroid hyperplasia, hemolytic anemia, erythroleukemia. C. Increased M to E ratio, myeloid hyperplasia, myeloid leukemias. Remember, bone marrow, M to E ratio, 3 to 1 to 4 to 1. Aspirate from the sternum and hip, or iliac crest, most common for morphology review. Romanowski stains. Ratio of cells to fat is 50% cells and 50% fat. Overall evaluation of cellularity is determined by a biopsy. White blood cell differential determine type of leukemia. Hemoglobin electrophoresis. 1. Cellulose acetate, pH 8.6, from cathode to anode, negative to positive. 2. Citrate agar, pH 6.2. Most other hemoglobins migrate with A at pH 6.2. Red cell disease states. Hemoglobinopathies. 1. Structural mutations, all except G, involve the beta chain. Hemoglobin S is valine for glutamic acid, 6th position beta chain. C. Lysine for glutamic acid, 6th position beta chain. D. East Indian individuals migrates with hemoglobin S at 8.6. E. Southeast Asian individuals migrates with HBC and A2 at 8.6, hyperchromic or microcytic. G. Most common alpha chain variant in African Americans migrates with hemoglobin S at pH 8.6. Hemoglobin S. Heterozygous, asymptomatic, sickle cell trait. Homozygous, severe chronic hemolytic anemia with many complications, or sickle cell disease. See sickle cells on right, not in trait. Sickle dex, reducing agent. Sodium dithionite causes hemoglobin S to precipitate, producing turbidity. Confirmed by electrophoresis. Cellulose acetate, pH 8.6, migrates with D, G, lipour. Citrate agar, pH 6.2, S separates from others. B. Hemoglobin C. Heterozygous, asymptomatic. Homozygous, mild chronic anemia. May see hemoglobin C crystals, which are bar-shaped, and target cells. In SC disease, crystals appear as hand-in-glove or Washington Monument. Confirmed by electrophoresis. Cellulose acetate migrates with A2, E, O, and C, Harlem citrate agar. C separates from others. 2. Decreased production of alpha or beta chains. A. Beta thalassemia. Decrease or absent production of beta chains. Microcytic hypochromic anemia. Increased hemoglobin A2 and F. Decreased or absent A. B. Alpha thalassemia. Decreased production of alpha chains. One deleted alpha gene minus alpha over alpha alpha. Silent carrier, normal CBC. 2 deleted alpha genes, minus alpha over minus alpha, or minus minus over alpha alpha. Mild microcytic hyperchromic anemia. 3 deleted alpha genes, minus minus over minus alpha. Hemoglobin H disease. Chronic hemolytic disease. Hemoglobin H, beta 4. Hemoglobin Bart's, gamma 4, present at birth. Hemoglobin H inclusions, or Heinz bodies. 4 deleted alpha genes, minus minus over minus minus. Hydrops fetalis, non-viable fetus. Classification of anemias. Anemias have decreased hemoglobin and hematocrit. If the MCV is low or microcytic, and it has a problem with the heme, it indicates iron deficiency, sideroblastic, or chronic disease or inflammation. If there's a problem with the globin, it indicates thalassemias or hemoglobin E. If the MCV is normal or normocytic, antibody destruction indicates hemolytic disease of the newborn, transfusion reaction, or autoimmune hemolytic anemia. Red blood cell membrane defect would indicate hereditary spherocytosis, or HS, hereditary elliptocytosis, or HE, or Paroxysmal nocturnal hemoglobinuria, PNH. Enzyme deficiency would indicate G6PD, pyruvate kinase, or PK. Decreased production or loss would indicate aplastic anemia, chronic renal disease, acute blood loss, or bone marrow infiltration. Hemoglobinopathies would indicate hemoglobin S or hemoglobin C. Other external actions would indicate antagonistic plasma factors or physical trauma. If the MCV is high or macrocytic, megaloblastic maturation would indicate B12 deficiency, folate deficiency, myeloproliferative neoplasms, myelodysplastic syndromes. Non-megaloblastic maturation would indicate liver disease or alcoholism. Anemia types and key lab findings. Microcytic or hypochromic. Iron deficiency lab findings. Decreased serum ferritin, decreased serum iron, increased TIBC, decreased percent saturation. Chronic disease or inflammation. Increased serum ferritin, decreased serum iron, decreased TIBC. Lead poisoning. Basophilic stippling, increased blood PB, increased FEP. Thalassemia trait. N serum iron, NTIBC, increased A2, increased F. Macrocytic. B12 deficiency, pernicious anemia or malabsorption dietary. Lab findings. Decreased B12, decreased reticulocytes, pancytopenia, oval macrocytes, hypersegmented Howell-Jolly bodies. If it's the pernicious anemia variation, it would be anti-IF positive, IF being intrinsic factor, increased MMA or methylmalonic acid, increased homocysteine. If it's malabsorption or dietary form, it's decreased B12, anti-intrinsic factor negative. Folate deficiency. Lab findings. Decreased folate levels, anti-intrinsic factor negative, decreased reticulocytes, oval macrocytes, hypersegmented polyneutrophils. Liver disease or alcoholism. Increased liver enzymes, target cells, round macrocytes. Normocytic or normochromic, antibody mediated. Increased bilirubin or decreased haptoglobin, DAT+. If it is PHC, it would have Donnelath-Landsteiner AB, anti-P specificity. If it's from cold agglutinin disease, it would have IgM AB, anti-1 specificity, cold agglutinin titer positive. Warm autoimmune hemolytic anemia, it would be IgG AB. Membrane defect. Hereditary spherocytosis would have spherocytes, increased MCHC, abnormal spectrin, band 3 defect. Hereditary elliptocytosis would have elliptocytes, increased 15% to 100%, abnormal spectrin. Hereditary stomatocytosis would have stomatocytes, abnormal sodium-potassium permeability. PNH would have CD55, CD59, FLAER test positive. Enzyme deficiency. G6PD would have decreased G6PD, Heinz bodies, and bite cells. Pyruvate kinase, PK, would have decreased PK and no Heinz bodies. Decreased production or loss would have aplastic anemia, dry tap bone marrow, hypocellular bone marrow, decreased reticulocytes and pancytopenia. Acute blood loss would have normal bone marrow and increased reticulocytes. Chronic or renal disease would have decreased EPO. Hemoglobin defects would have definitive poikilocytes on smear, which would be like HBC crystals, sickle cells, SC crystals, etc., and HB electrophoresis. Physical trauma would have microangiopathic hemolytic anemia, MAHA. HUS would have schistocytes, decreased platelets, acute renal failure, bacterial infection. TTP would have schistocytes, decreased platelets, neurological symptoms, normal coagulation studies, and decreased ADAMTS13. DIC, schistocytes, decreased platelets, abnormal coagulation studies, positive D-dimer. HELLP would have schistocytes, decreased platelets, and increased liver enzymes. Erythrocytosis. 1. Increased number of red cells, increased hemoglobin, increased hematocrit. 2. Relative decreased plasma volume, burns, dehydration, Gace-Bach syndrome. 3. Absolute increased red cell mass. A. Primary decreased EPO, normal O2 saturation, polycythemia vera. B. Secondary increased EPO, decreased O2 saturation, chronic obstructive lung disease, high O2 affinity hemoglobin. White cell disease states. Hereditary conditions. Alder-Riley has large eosinophilic granules, increased mucopolysaccharides, Hunter and Hurler. Chidiac-Higashi has large lysosomes, fusion of primary granules, occurs in albinism and increased susceptibility to infection. May-Heglin has large platelets, decreased number, Dolly bodies in segmented neutrophils, monos, and lymphocytes. Does not affect leukocyte function. Pelger-Hewitt has hyposegmented polys, normal function. Myeloproliferative diseases. Number 1. Myelodysplastic syndromes. Neoplastic clonal stem cell disorders characterized by cytopenias and bone marrow dysbiosis. A. Refractory anemia, less than 5% blasts. B. Refractory anemia with ring sideroblasts, less than 5% blasts and ring sideroblasts. C. Refractory anemia with excess blasts, 5 to 20% blasts. 2. Myeloproliferative neoplasms. Neoplastic clonal disorders characterized by increases in red cells, white blood cells, and or platelets. A. Primary myelofibrosis, dry tap, teardrop-shaped red blood cell, bone marrow fibrosis. B. Essential thrombocythemia, increased megakaryocytes, platelets, less than 1 million per millimeter cubed. C. Chronic myelogenous leukemia, increased myelocytic precursors from blast to mature neutrophil, decreased LAP, Philadelphia chromosome, pH T 9 to 22 BCR per ABL fusion gene. D. Polycythemia vera, pancytosis, Janus kinase 2 mutation. 3. Acute myeloid leukemias, AML. A. WHO classification, over 20% blasts. AML with recurrent chromosomal abnormalities. T 8 to 21, increased myeloblasts plus our rods. INV 16 or T 16 to 16, increased eosinophils. T15 to 17, increased promyelocytes. 11q23, increased monocytoid precursors. AML with dysplasia may follow MDS. AML and MDS therapy related. AML of ambiguous lineage. AML not otherwise specified defaults to the FAB classification. B. French, American, British, FAB classification, over 30% blasts. Leukemoid reaction versus CML. LAP has increased leukemoid and decreased CML. Toxic granulation has leukemoid but doesn't have CML. Dolly bodies have leukemoid but don't have CML. PH, BCR, ABL don't have leukemoid but have CML. AML with recurrent genetic abnormalities. T15 to 17 retinoic acid receptor alpha gene is associated with promyelocytes with multiple Auer rods or phagocells. T8 to 21 associated with myeloblast with maturation and Auer rods. T16 to 16 or INV16 is associated with myeloblasts, monoblasts, and increased eosinophils. Lymphoproliferative neoplasms. 1. Acute lymphoblastic anemia or lymphoma, ALL or LBL. A. Precursor B cell. CD10+, CD19+, CD22+, CD24+. T12 to 21 greater than ETV6 run X1 fusion gene. B. Precursor T cell, CD2+, CD4+, CD5+, CD8+. Mediastinal mass presentation. 2. Chronic lymphoid neoplasms. A. Chronic lymphocytic leukemia or lymphoma, CLL. Mature lymphocytes, soccer ball nucleus. CD19+, CD20+, CD23+, and CD5+. B. Hairy cell leukemia, HCL. Mature lymphocytes with cytoplasmic projections, pancytopenia, splenomegaly. CD103+, CD11C+, CD25+. C. Prolymphocytic leukemia, over 15% prolymphocytes, usually B cell lineage. 3. Plasma cell neoplasms. A. Plasma cell myeloma, multiple myeloma. Bone pain, multiple lytic lesions. Sheets of plasma cells in BM. Rouleau, red cells appear as a stack of coins on a blood smear. Increased serum protein, IgG or IgA monoclonal spike. Increased calcium++. Urinary excretion of light chains, Bence-Jones protein. B. Plasma cell leukemia. Increased 20% plasma cells in peripheral circulation. C. Waldenstrom macroglobulinemia. Normal bone scan. Increased IgM. Increased serum viscosity. 4. Hodgkin lymphoma. A. Reed-Sternberg cell. B. Stepwise predictable speed. C. Bimodal incidence. 5. Burkitt lymphoma. A. Associated with EBV and HIV. B. TA14. C. CD19+, CD10+, and CD5-. Plasma cell myeloma versus Waldenstrom. Bone involvement in multiple myeloma, but not in Waldenstrom. Serum viscosity plus or minus in multiple myeloma, increased twice in Waldenstrom. Immunoglobulin, IgG, Bence-Jones in multiple myeloma, IgM heavy chain in Waldenstrom. Special cytochemical stains, inclusions, and markers. Prussian blue indicates iron, significance sideroblastic anemia or iron overload. LAP indicates leukocyte alkaline phosphatase, significance increased leukemoid reaction, P. vera, decreased CML. Peroxidase Sudan black indicates myeloperoxidase or lipid. Significance: myeloid precursors positive, lymphoid precursors negative. Specific esterase, chloroacetate esterase, indicates granulocyte precursors. Significance: negative in monocytic leukemia. Nonspecific esterase, alpha naphthyl butyrate, monocyte precursors, positive in monocytic leukemias. Our rods, coalition of 1-degree granules. Significance: acute myeloid leukemia. CD13, CD33, and CD117 indicates myeloid lineage. Significance: myeloid or monocytoid leukemias. CD41, CD42, and CD61 indicates megakaryocytes. Significance: megakaryocytic leukemia. CD14 and CD64 indicate monocyte lineage. Significance: monocytoid leukemias. CD2, CD3, CD5, and CD7 indicates T lineage. Significance: T cell neoplasms. CD10, CALA, which is common acute lymphocytic leukemia antigen. CD19 and CD20 indicate B lineage, which significance B cell neoplasms. CD34 indicates stem cells. Significance: stem cells for transplantation acute leukemia. CD38, CD138 indicates plasma cell markers. Significance: plasma cell multiple myeloma. CD71 indicates transferrin receptor. Significance: erythroleukemia. CD45 indicates common leukocyte antigen. Significance: found on all leukocytes. CD103, CD11C, and CD25 indicates HCL. Significance: also seen in other lymphoproliferative disorders. JAK2 mutation indicates PV. Significance: also seen in other MPN. Lipid storage disorders. Gaucher. Accumulated lipid enzyme glucocerebroside ACE. Lab diagnosis: BM macrophages with wrinkled or striated cytoplasm. Niemann-Pick. Accumulated lipid enzyme sphingomyelinase. Lab diagnosis: bone marrow macrophages with globular or foamy cytoplasm. See blue histiocytes. Hematology sample questions. Number 1. The major iron storage compound is ferritin. Hemosiderin is a long-term winter-insoluble iron storage compound, but not the major one. Hemosiderin can be found in macrophage lysosomal membranes and seen in bone marrow aspirates stained with Prussian blue. Siderotic granules are iron inclusions found in red cells stained with Prussian blue. Transferrin is the transport protein specific for iron. 2. How would the following results on a 32-year-old adult female be interpreted? Hemoglobin 9 grams per deciliter, MCV 74 fluid ounces, MCH 27 pg, MCHC 30 grams per deciliter, RDW 19%, serum ferritin 14 ng per ml, N equals 20 to 250 ng per ml. Serum iron 29 grams per deciliter, N equals 70 to 200 grams per deciliter. TIBC is 590 grams per deciliter. Normal is 250 to 435 grams per deciliter. Saturation percent 5. This indicates iron deficiency anemia. An RDW greater than 14.5%, decreased iron or increased TIBC, and greatly decreased ferritin, indicating no iron stores, support this diagnosis. In anemia of chronic inflammation, ferritin would not be decreased and the TIBC would be decreased. In thalassemia minor, the iron and TIBC would probably be normal and the anemia would be less severe. Also, the RDW would probably be in the normal range. Sideroblastic anemia would have increased ferritin and increased serum iron. Number 3. How would the following results on a 72-year-old female be interpretive? Hemoglobin 6, MCV 114, MHC 39, MCHC 34, RDW 18.5%, oval macrocytes on right stain, reticulocyte count 1.2%, serum B12 55, serum folate 7, anti-intrinsic factor antibodies positive. This indicates pernicious anemia. Oval macrocytes, decreased B12, and positive IF antibodies are all indicators of pernicious anemia. It's not folate deficiency because the folate is normal. In liver disease, the anti-IF antibodies would not be positive. In reticulocytosis, the reticulocyte count would not be normal. 4. Beta thalassemia results from decreased synthesis of globin chains. Hemoglobin C disease, hemoglobin M, and sickle cell disease all result from structural abnormalities. 5. The normal M to E ratio is between 3 to 1 and 4 to 1. 6. A patient with a negative dithionite solubility test has a band in the A region and a band in the S region on cellulose acetate hemoglobin electrophoresis at pH 8.6. On citrate agar, there is only a band in the A region. Which of the following is compatible with these results? HBAD is compatible with these results. HBAS would give a positive solubility and would show a separate band in the S region on citrate agar. HBE would give a negative solubility test but would migrate to the C position on cellulose acetate. HBC Harlem would give a positive solubility test and would migrate to the C position on cellulose acetate. 7. The failure of granulocytes to develop past the band or two-lobe stage is characteristic of Pelger-Hewitt anomaly. Bernard-Soulier syndrome is a platelet adhesion problem characterized by giant platelets. Chediak-Higashi syndrome is characterized by giant lysosomes in leukocytes. May-Hegland anomaly is characterized by giant platelets and Dolly bodies. 8. A patient with an elevated white blood cell count with neutrophilia, a left shift, toxic granulation, vacuoles, Dolly bodies, and an increased LAP probably has bacterial sepsis. Acute myelogenous leukemia would have a predominance of lymphocytes and an LAP would not be performed. Chronic myelogenous leukemia would have a LAP score that was decreased. Viral sepsis would show a normal white blood cell count and LAP score with no Dolly bodies, toxic granulation, or vacuoles seen. Number 9. The following results were obtained on an automated CBC. Hemoglobin 11.2, hematocrit 27%, red blood cells 2.1 times 10 to the 6th, MCV 128, MCH 53.3, MCHC 41.5, RDW 19%. All results are flagged. The technologist found no evidence of clots in the sample. What should be done next? Warm the sample to 37 degrees and rerun. These results violate the rule of 3 and are strongly suggestive of a cold agglutinin. Warming the sample to 37 degrees will usually cause the agglutination to disperse. A redraw would not be the first course of action. You can't report the results if the controls are in range, and you can't rerun the sample and sign out if the results match, because the results are flagged and indicate some type of interference or erroneous result. 10. Plasma cells evolve from B cells, which are lymphocytes. 11. In performing a manual white blood cell count, 0.02 milliliters of blood was diluted with 1.98 milliliters of ammonium oxalate. An average of 50 cells were counted using a Neubauer hemocytometer. What is the patient's white count? The formula for calculating manual cell counts is as follows. Number of cells counted times 1 over the total volume times the dilution factor. The dilution is 1 to 100, so the dilution factor is 100. Volume factor can be eliminated by taking 10% of the number of cells counted and adding this to the number of cells counted. So you do 50 times 0.1 equals 5, and then 50 plus 5 is 55. So 55 times 100 is 5,500 millimeters cubed. 12. A 4 milliliter EDTA tube was received in a lab containing approximately 1 milliliter of whole blood. If performed on this sample, which of the following manual lab tests is most likely to be affected? The sed rate would be affected. Underfilling results in excess EDTA causes the red cells to shrink. This would cause the sed rate to be falsely decreased since the smaller cells will settle out more slowly. The other values would probably not be affected. The other values being hemoglobin reticulocyte count and white blood cell count. 13. A peripheral blood smear stained with Prussian blue demonstrates siderocytes. On a right stained smear, what would be expected? Pappenheimer bodies would be expected. Siderotic granules are composed of iron and on a right stained smear appear as Pappenheimer bodies within the red cell. They are frequently seen in sideroblastic anemia, alcoholism, thalassemia, and some pre-leukemic states. Basophilic stippling is composed of RNA remnants and does not stain with Prussian blue. It's associated with lead poisoning, thalassemia, and hemolytic anemias. Howell Jolly bodies are composed of DNA remnants and is associated with hyposplenism, pernicious anemia, and thalassemia. Heinz bodies are denatured hemoglobin and not seen on a right stained smear and are associated with G6PD deficiency, exposure to oxidizing drugs, alpha thalassemia, and unstable hemoglobins. 14. A bone marrow differential performed on a patient showed 20% blasts. Flow cytometry studies demonstrated the blasts to be positive for CD10, CD19, CD22, and negative for CD13 and CD33. Which of the following diseases is most compatible with these findings? ALL would be most compatible with these findings. Over 20% blast in the bone marrow is associated with acute leukemias. CD10, CD19, and CD22 are indicative of B lineage ALL. AML would be positive for CD13 and CD33. CML and CLL would not have over 20% blasts in the bone marrow. Number 15. Which of the following is diagnostic of acute promyelocytic leukemia? T1517 translocation is diagnostic of APL. Number 16. Plasma cell multiple myeloma may be suspected if which of the following is seen on a peripheral smear? Rouleau. Due to increased plasma proteins, monoglobal immunoglobulin may be seen in plasma cell myeloma. The serum viscosity is increased. The albumin-globulin ratio is decreased. Basophilic stippling is seen in conditions associated with disturbed erythropoiesis. Bizarre blast cells are seen in leukemia states. Hypersegmented neutrophils are seen in pernicious anemia. Number 17. Which parameter is most likely affected by lipemia? Hemoglobin is measured optically, and lipemia will cause a false increased value. MCV, white blood cell count, and red blood cell count are measured by the impedance principle and are not affected by lipemia.